Hello, this is Eric Topol for Medscape, and with me is my co-host Abraham Verghese for our new podcast on medicine and the machine. And today we're really privileged to have with us Dr. Ebony Hilton, University of Virginia faculty and anesthesiologist. And just a little bit of background before we get started. Dr. Hilton comes from South Carolina, a little town, I guess, called Little Africa, one of three girls. She had her training at the Medical University of South Carolina, which she became the first anesthesiologist in critical care medicine on the faculty there since its opening in 1824. So she's kind of a distinguished person. And she joined the University of Virginia, my old stomping grounds for where I went to college. I want to hear a little bit more about that. Recently won an award from the National Newspaper Publishing Association, writes children's books, works a lot on health disparities, does good stock consulting, a contributor on MSNBC, all this stuff. It's amazing. So let's welcome you, Ebony.
Well, thank you all for having me. It's very nice to meet you.
Well, I'll get things started, give you some kind of full range of where you want to go, but you recently tweeted, I wish I had an interview where I'm allowed to just ramble on. So we're going to let you ramble on. This is your big chance.
Right. I mean, because it really is one of those things of when you think about the intersection or what classifies as health, right? And all the social determinants of health, you really have to think about the intersection of every facet of society, from education, housing, transportation, the influence of poverty, the influence of privilege. Because right now with this pandemic, we're literally seeing how privilege and racial injustice really are two ends of the same stick. And both of those ends, when overworked, has a cost of life, because we're seeing how privilege is leading some to make decisions that aren't necessarily favorable for public health measures. And so, yeah, you can ramble on for days in talking about it.
Ebony, it's a great pleasure for me to get to meet you. I've been reading some of your key papers in critical care and about the workforce. And I must confess that that word intersectionality is a new word for me, and I have a new understanding of it. The fact that a woman faces certain inequities, but then a woman who's an immigrant, who's also a woman of color, or is gender fluid, for example, faces further levels and levels of complexity. And I think you wrote about that very beautifully. But maybe you could talk a little bit about the critical care workforce, because I was first of all astounded to read that 40% of critical care specialists are women. That to me was a larger number than I suspected, but not in leadership. And talk a little bit about those choices and where we go from there.
Right. I think historically, it's just medicine in ways is a business like any other business, right? And what we see is that persons of positions of power typically are men and typically are white men. And that stretches across the board. And we do know those studies show that concordance, racial concordance, gender concordance, that outcomes can actually be better for those populations by which we serve. And so it behooves the medical community to move in the direction of where our patient demographics has always been and will continue to be more and more diverse. But we're seeing that in our med school classes as far as gender diversity. We know that women are coming more and more into the medical field. But the question is, when we're talking about intersectionality, I think what we oftentimes miss is the intersection of gender and race. Black women were oftentimes left out, and we become invisible. And it's not only in the workplace model. When we think about affirmative action, literally the greatest benefactor of affirmative action is white women. They really did gain a foothold in society, but Black women in totality, we still have the lowest unemployment, the lowest income earned. And when I look at health outcomes, we unfortunately have worse health outcomes even in comparison to men. And to give you a proud example of that, I tweeted today about intersectionality of gender and race and looking at COVID outcomes, because over and over again we hear men have worse outcomes than women. But the truth of the matter is that Black women We are 3 times more likely to die than white men, 3 times more likely to die than Asian men. We have higher death rates at younger ages for both male and female across the board for any race, except for Black men. So it's Black men and then Black women and then everyone else. But we get left out of this discussion, and without naming us specifically and naming race specifically and trying to figure out why is it that race trumps socioeconomic status? Why is it that race trumps educational attainment? Why is it that race, trumps even if you are more compliant with your medical practice and you're trying to do what's best? Why is it that race still trumps that as far as having negative outcomes?
I think that what you're emphasizing is so critical. That is the idea that when you look at just one variable like gender, you can be misled, and you're really accentuate that. Now, one of the questions about is remedies for this, and I wonder what your views are if the U.S. had universal health care, because we have the worst inequities here. Do you think that if you could just flip a switch and all of a sudden we had universal healthcare, would that get this thing on track, or what is the way to get this right?
Right, and I would love to say yes, but Twitter has been a great resource for me this last year, and getting to meet other people of different backgrounds. And one of the persons I met was a physician from the UK. And after one of my Twitter rants about the racial inequities, he wrote and said, we too are seeing this with our BAME population. BAME is what they talk about, the Black and minority ethnicity groups. And what they found was that they too have racial disparities and ethnic disparities despite having universal health care, right? So it's not just access that's an issue. We have to also think about the fact, not that I don't think we need access, don't get me wrong, I am all about universal health care. And I think the passing of Medicaid and the push for that by the NMA back in the 1960s to say, hey, if federal dollars are tied to this insurance, then you can't deny Black people from coming into this hospital. I mean, that's one of the reasons why we have this in the first place. But I do think access is an issue, but we have to have accountability in medicine. And this is where I think we can really learn from the intersection of protests and pandemic. With the George Floyd protests, it really brought to the forefront of how we need police reform, because no, all police officers are not bad. We know that. The majority of police officers are very, very good, and they try to do their best. But there has to be some form of accountability when there is that outlier of where we know something has happened. And the same thing needs to happen in medicine. I feel personally that there has to be some form of accountability when we see that study after study shows that, again, and to give you an example, I'm a double board certified anesthesiologist, and yet my child is twice as likely to die before their first birthday than if I were a white woman with a 3rd grade education. And I'm not saying there should be a 2-tier system, but what I am saying is that there is a 2-tier system. And why is it that when Black women go into the hospital seeking care, why is it that we're less likely to get steroids if we go into preterm labor, knowing that our babies would fare worse and their lung development isn't there? But studies show that Black women and Hispanic women are less likely to get that intervention for us. Studies also show that if I have a Black physician as a Black woman, that my child, the likelihood that my child will die is cut in half because I have race concordance. That shouldn't be the case, right? So how do we start to track and give physicians, we do implicit and explicit bias training all the time, but do we get a report card that reflects back to us, what are your outcomes along the lines of race? What are your outcomes along the lines of gender? Along the lines of even the primary language of your patient? We have the ability to do that. We simply don't do it though.
I think the discussion around gender too often, I think, focuses on the pipeline and on the glass ceiling and on achieving numbers. But you make a great point that this is also more about the patient. There's actually some extraordinary data that suggests that surgical outcomes, cardiac outcomes are better for women performing these things than for men. No one has quite explained them. The differences are real, but nevertheless, I think, it raises the question of maybe that should be our motivation, is this is better for patient care, because I think focusing too narrowly on numbers misses the point completely, as you say.
It completely misses the point, especially when, again, every N of one is someone's at bare minimum son or daughter, right? And they deserve to know that when they do pass, that someone actually cares enough to investigate the why behind it. And we have M&M in medicine, right, where we sit in our individual small circles or groups to try to figure this out. But collectively, we as a society, medical society, and medical community needs to reflect back and say, why is it that racial disparities in particular have not changed since Civil War times, despite the advancement of health, despite the advancement of diagnostic capabilities and therapeutics? Why is it that that there's been this paucity of life for Black people, and specifically for Black men, since the beginning of time, where they literally are not even reaching a life expectancy that white men were reaching back in the 1970s, 1980s. And we know how much we have gained. But and with this pandemic, I think it really has pushed to the forefront this screaming that Black people have been screaming of, why are we dying and no one's looking and no one cares, because it happened so fast that you can't ignore it. I mean, with the pandemic, the first 6 months of 2020, Black men particularly lost 3 years of life expectancy. And their life expectancy in Virginia was only 72 to begin with before COVID. And so we are literally looking at Black men and saying, don't expect to see 70. Live your full life, because 60, 65, that may be the end of the road for you. And that is just absolutely gut-wrenching for me. And it should be something that keeps every physician up at night to figure out why.
Well, your point here is, again, especially astute, because if you look at the data, there's been a 2-year loss of life overall for Americans from the pandemic, but it's much higher in people of color. Now, one of the things I wanted to get to was maternal mortality, especially among mothers and newborns. So here, this has been an area of neglect long before the pandemic. It's been atrocious. And we have the worst in the US of all the OECD countries, all 37 of them. And our statistics for maternal mortality are outrageous. And nothing seems to be getting done about it. We mounted a study, Power Mom, so we try to get as many people, pregnant women, engaged so we can start to get to the roots of this. But what's your sense here about why the US is such an outlier on such an important group of people?
Right. I mean, because you can literally tell the health of a nation based on how their mothers and their children do, right? Because it's usually young, healthy women who are getting pregnant. And so that we should not be dying at the rate that we are. But I think you can tell where the country puts priority based on where they put their money. And we know that Black women, again, no one wants to die, and definitely no one wants to bury their child. You really, there's an intention put behind it to try to get the best of care. But when I'm thinking about disparities, I think about it in 3 different buckets. And you think about a Venn diagram with overlapping circles, right? And so we have the individual component. How do you smoke? Do you drink? What are some things that you can change and influence for yourself, right? Are you medication compliance? Those sorts of things. You think about the community bucket. That literally is where your zip code has a more important determinant of your health than your genetic code. And we can think about what are the impacts of environmental racism, we can think about industrialization of certain industries and the toxins spewed in the air and water, and what does that do to you? We can think about the insults of poverty within that community, the availability of healthcare resources, and the fact that Black and brown communities are literally twice as likely to not have a hospital and 4 times as likely to not have a grocery store within their communities. What does that contribute to it? And then the third bucket being the healthcare system itself. What happens on the capillary level when someone walks into the hospital? Do I treat you the same? What are the impacts of implicit and explicit bias for the individual provider? And then what are also the interjections of racism into the medical policies that we put in place, and how do they contribute also to outcomes? And we can definitely talk about that as it is linked to COVID outcomes. But that's what I think of with a Black mother, that we have so much that is literally outside of our ability to control, that determines how our fetus is allowed to develop. And what are the stressors when you're talking about, again, the rambling on and the intersections of all these things overlapping. When you talk about the impact of generational wealth and the lack thereof, when you talk about the influence of how the Homestead Act and the GI Bill and all these, welfare programs that were beneficial for predominantly white Americans, how it didn't filter down to Black people, and the influence of that poverty within that community and the stressors that it causes is a huge factor of why Black women are 50% more likely to go into preterm labor, just based on the community they live in, based on redlining and the insults of those racist policies that still structure our communities today. And then you take that insult and you put yourself inside of the hospital, where again, studies show that you're less likely to get steroids for your child, that we know those steroids can help your baby to breathe better. And you're less likely to get those steroids. We already know about the less likelihood to get pain management, and pain is not just something that you can just brush off, because pain is linked to something, including abruption of your placenta, that is more likely to be missed with Black women, and other complicating factors like what Serena Williams experienced, right? Of where you're having complications of blood clots and no one's listening to you. All these things tie into reasons why we die, and reasons why, unfortunately, our children are twice as likely to die too.
I think many of our listeners are probably in administration and well-intentioned, but may not necessarily know quite how to go about bringing about a change in a big organization. And I know that you have a consultancy where you basically give advice. And can you share some general principles of what you think organizations need to do, and how do you bring that about? How do you measure it?
Right. I think that the first thing is we have to listen more than we speak, because oftentimes what I tell people all the time is my diplomas, my degrees, they mean nothing to me in comparison to my lived life experience, because I come from a single parent home. And with that, I had to watch my mom navigate the system. I understand when you say that vaccines are available from 9 to 5, that's the time she works. And if she doesn't go to work, she cannot feed us. So it's not accessible. You can say it, and I say all the time, we center privilege with our actions, and then we state equity in theory, because what we're doing doesn't work, right? And so I would tell administrations and the leaderships of organizations that the very person that you feel like is the most vulnerable should be the very person that's at your table speaking the loudest, and you need to listen. You need to make it in a situation of where they can be vulnerable with you and they don't feel judged. And if that means you leaving the room, then so be it. But it needs to, you have to have authentic conversation, because that's where you can get to the root. Because I can give you an example. Here at the University of Virginia, we did tried to do a fantastic job at being equitable in our approach to COVID-19. But from the very beginning of the pandemic, I started tweeting, we are going to see racial health disparities. And I would do it over and over again. And there were a couple of people, journalists, that finally said, why do you keep saying this? Like, there are no numbers. What do you mean? And I said, Black people, we die at higher rates for 9 out of 15 leading causes of death. This should be no different. And I don't want to get to the point of where we're reporting the numbers if we can possibly stop it. And so one of the things at the University of Virginia, I started asking, what are our outcomes and what are we doing right now? And they, the pulmonary group created a COVID clinic. So basically this is where community persons, if you had COVID, you can go to get tested and initiation of treatment. And I said, okay, can you tell me the process, that how this works? And they said, well, you get, if you call your primary care physician and they can refer you to our clinic. And I said, well, let's stop. I said, because that's racist. And they're like, no, wait till we tell you what happens. I was like, yeah, but you can't tell me what happens next because the first step is flawed. Because right now we know millions of people are now unemployed. And if I have to choose between paying a copay or feeding my children, I have to feed my children. Not only that, we know before the pandemic that the most vulnerable persons did not have a primary care physician because they can't afford, they don't have insurance, right? And so that first step is already going to be skewed towards being pro-privilege. So to prove the point, I said, let's run the numbers. Tell me who we're seeing in clinic. And 76% were white. 11% were African American. And I said, well, if they're not going there, they're going to the emergency department. So let's run those numbers. And what we found there was through the screening process that even those persons, white people who screened negative, they did not have signs and symptoms of COVID. What we found was that they were still more likely to be tested for COVID, and that Black people, even if they screened positive, they were less likely than white to be actually afforded a test. And the test positivity for Black people was 21%, and test positivity for white people was 3%. So the part I made there was, okay, well, let's have an alert that pops up that if someone screens positive and you do not test them, you have to put in a reason as to why. And if someone screens negative and you still decide to test them, you need to put in a reason why, to again tie some accountability to our actions, because there is no checkpoint between patient and physician and provider.
Medicine and the Machine will be right back.
Welcome to Medscape's latest podcast series, Medicine and the Machine, featuring Medscape's editor-in-chief, Dr. Eric Topol, and master storyteller and clinician, Dr. Abraham Verghese. Remember, you can find the latest in medical news, expert perspectives, clinical tools, continuing medical education, and more at medscape.com.
Along the way, Ebony, you've shown yourself to be a gifted communicator, and obviously it's not just through Twitter. You are now increasingly having a voice on cable television, and you've written children's books. Tell us about your path, because I think it's really vital that your voice has become manifest in this, not just in the pandemic, but of course in general medicine. And a lot of doctors are reluctant to speak out. Everyone has a chance, but what is it? What has gotten you into this mode of being able to voice your opinions, do it in a very articulate way, not being afraid of some of the repercussions, because all of us who do post things, we get a backlash, we get all sorts of things that are not desirable to make our days more complicated. So tell us about that.
It's one of those things I say all the time. If you can, I want to talk myself out of a job. That if you, and I say, as bluntly as possible, if you want me to shut up, then fix the system, and I will. Because the thing that led me into medicine in the first place, like I said, I came from a single parent home. I have two sisters on either side of me. And my little sister, when I was 8 years old, asked my mom, could we have a brother? And I was 8, and my mom all of a sudden just started breaking down crying. And this woman was the strongest woman I've ever met in my life still. She does not cry easily. And she began to tell us that my parents' first child was actually a little boy, that they were both in high school when she became pregnant, or they became pregnant. She was going to a clinic to get her prenatal care. They ran some tests, and she still doesn't know what type of test, but she felt a sharp pain. And she said that when she went home, she started leaking fluid. She called the clinic and said, hey, my underwear are wet, is this okay? And they said, yes, everything is fine, you'll be okay, we'll see you back at your next visit. But unfortunately, she ended up going into labor a couple days, within 2 days. And my brother, who would have been 43 years old this year, lived for 3 days and passed away. And that was my first introduction to medicine. And I decided in that moment, as an 8-year-old, I am going to be a doctor so other mothers don't have to cry like this, as naive as that sounds. And as crazy as it sounds, I never had a plan B. That was it. I grew up in a very low, you could say almost, I got free lunch, just put it that way, in school. And growing up in medicine, and I really do mean I did that, I grew up in medicine, to learn that that those same inequities exist today really bothered me. To learn that the way that we have medical training speaks nothing of the racial injustices that have happened, from not only Tuskegee, because Tuskegee is a big part of it, but there are many injustices that continues to happen, and policies that are put out that literally we know have negative impact on certain communities, and we remain silent. And I feel like physicians, we at one point, or at least in my naive state of being an 8-year-old, thought the doctors were the greatest minds available. So how are we silent, right? How are we silent in our position and not influencing what happens within outside of our community walls and within the walls of the hospital itself, because we know right from wrong. But along the way, we have lost that confidence in voice, I feel. So when I say things, I literally am unapologetic in speaking truth, because everything I say is really tied to the fact that my brother would have been able to say it if he was allowed to live, and he can't, so I will.
Right. And there's so few activists in medicine. I mean, you are the prototype of the young activists, young physician activists. We're the old dogs, Abraham and I. But do you think we can promote more people like you in the years ahead? Because most physicians just keep their head down. They don't want to really get out there and start to rally and change things that are desperately need to change.
I mean, it's a cost to it. I tell people that all the time. I know I don't know what it's going to cost me in my life, but I know what chronic stress costs. And I know chronic stress is linked to cancers, it's linked to hypertension, to diabetes. I have to watch myself very closely. There's the study that I was giving you about the fact that as a double board certified anesthesiologist, my child is twice as likely to die than a white woman with a 3rd grade education. Dr. Keisha Bentley Edwards, she's out of Duke Institute that published that paper. And she's quoted by saying, when you're the only one in the room, when you're in this circle of elites, that there's a toll to pay. And being in this position, to go against the grain, to literally tweet out at the CDC, knowing that I'm going to have we have calls set up where we can talk to the White House task force every now and then. I know I'm going to see them face to face, and I tell them after every meeting, I'm going to tweet and I'm going to go directly towards you, because the way that you have rolled out these phase groupings, phase 1A, phase 1B, phase 1C, are literally pro-white in design. Because when you go about a disease process that's race, and you go about policies that are race neutral in a racial health disparity laden disease process, and it's pro-privilege or it's pro-white in design. And that's what we saw with the vaccine rollout. Phase 1A was healthcare workers and nursing home residents, of which, healthcare workers, 60% white, nursing home residents, it costs money to put your family members there, 77% white. Even when the phase 1B, initially they said 75 and older, and then they dropped it down to 65 and older. But we know in America, again, there's a paucity of life for African Americans. And if you're 65 and older in the United States of America, 78% of them are white. And then you got down even to when they said the essential workers. Well, we know that, again, by April 2020, less than 50% of all Black adults actually had a job. They were the first ones fired. So you're tying this life-saving intervention that we know had higher infection rates, higher hospitalization rates, and higher death rates for Black and brown communities, but you're tying the intervention that could potentially save their lives to age, of which they die at younger ages, and to occupation, of which they are less likely to actually have a job. And the only qualifier that really encompassed and taught the Black community at large was that if you had a pre-existing condition. So what the CDC basically said in their policy formation was that, yeah, Black people, even though you're dying at higher rates and at younger ages, and although we see that you've lost 3 years of life expectancy, in order for you to qualify to get the early recipient, to be the early recipient of this life-saving intervention, you need to have come into 2020 with at least one of your organs dead and gone. You either needed to have heart failure, kidney failure, cancer, diabetes. You needed to have something wrong with you. Whereas white people, white Americans, if you lived a nice life to see the age of 75, come on in. You can be in a 3,000 square foot home with only yourself living there, where you're able to socially distance and work via Zoom. But you come on in and get this shot, and Black people will see you in April. And that's, if you look at the data about how the vaccines were rolled out, in January is only 5% African American vaccine uptake. Upwards to April, it ended up being 9%, and then past April, that's when Black percentage of uptake began to match that of white Americans. It wasn't that we were hesitant, we were denied.
You know, talking about vaccine denial and hesitancy, you've been very brave about speaking out about that and countering the myths. Within the African American community, my experience, limited experience here, is that there is also a lot of reservation, but it's not politically based. It's based on general suspicion of you know, this kind of work. How do you overcome that in your community? What do you say? What do you do to increase vaccine rates?
Right. For one, I try to lead by example. I was the first person to be vaccinated at the University of Virginia, and I wanted to lead by that, to say, if I'm going to tell you to do it to your body, I'll do it to mine, without knowing, you know, not having someone to look and say, okay, it'll be okay. I want you to trust me. But for two, I knew from the very beginning, if you look at it, the narrative for that it was vaccine hesitant was pushed out even before the vaccines were approved. It started this rhetoric back in November, in the very early part of December, and I was like, stop saying that. For one, don't just label it for the Black community, because when you think about, again, I think in terms of buckets, because my mind does that, but I think about 4 large buckets when you think about vaccine hesitancy. African American community, for sure, because it's rooted in suspicions of the government. We can go to Tuskegee, of which that whistle was blown only 10 years before I was born. So that tells you that my grandmother and my mother were very much alive when those reports were coming out. But we don't have to stop there. We can talk about Flint, Michigan, water crisis, where they still don't have clean water to this day. And you're sitting here seeing brown water come out, and you're telling me that it's okay, as if I'm stupid, right? That's still an injustice that we're dealing with. So that's the African American community that we can deal with. But we also have the Hispanic community, and the fear that if I come into, especially our undocumented brothers and sisters, like, if I come in to get this vaccine, will I get deported, right? The hesitancy that's there. Then you have these other 2 buckets, though, that never really got mentioned. And I used to tweet about this all the time. You have the anti-vaxxers that have been anti-vaxxers for decades, that were largely white, college educated women, right? That really held up that bucket. And then the 4th bucket being the COVID hoaxers, that the GOP heavy Trump followers. 4 big buckets. 2 large buckets. If we're thinking about literally that last bucket, that was 74 million people that voted for President Trump, right? So those 2 large buckets for white Americans barely got mentioned. And I wrote an op-ed piece that no one would publish, but where it literally said, "Dear white America, you're in danger, girl." Like, you know, Whoopi Goldberg with Ghost movie, when she was like, "You're in danger." Because I spoke to white America about, I want you to actually see that vaccine hesitancy really is going to be an issue and a very big problem for you, because if we look at the changes of the racial health disparities, it used to be that Black and brown people were 6 to 8 times more likely to die from COVID. Now that number is cut down to 2, which is still bad, but but it's not because Black people are dying less, it's because white people are dying more, right? If you look at the death count from September, October, for white Americans, it was right around 12 to 15,000 each month. But then after Thanksgiving, it went to 27,000. After Christmas, it went to 42,000. After New Year's, in January, it went to 47,000. And between February 2nd and March the 2nd, 58,000 white Americans died from COVID-19. And it's something that, again, these two ends of the same stick with racial injustice and privilege, they are both deadly. And we concentrate messaging to the Black community, and we constantly tell them things like, oh, you're vaccine hesitant, you're vaccine hesitant. Meanwhile, Black people are saying, we will wrap ourselves around this building waiting in line, just like we have to wait to vote, right? We will wrap around waiting to try to get this vaccine at this mobile clinic because we got the Plan B option of healthcare. Instead of a hospital being in our community, we have to go to our church parking lot. We'll talk about that at another time, but we will show you that we're not as hesitant. We're curious. We want you to tell us the truth about it, but we will show up because we're tired of dying. And we've been screaming this for generations. Stop blaming us for being non-compliant. Stop when we can't afford our medication, right? Because we don't have jobs that we're getting paid the same amount, even if we have the same skill level. Stop blaming us for hypertension and diabetes when you know we don't have a grocery store within our community, but all we see are McDonald's, Taco Bell's, and Burger King that the city literally says it's okay and deemed safe to be placed in our community. Stop blaming us for asthma and things like that when you know you put an industry that spews toxin in our air for our children to breathe. Stop blaming us for things when we as tax-paying citizens are giving our money to the government and saying, can it be trickled back to us? Where we can have great ventilation systems in our schools in the middle of COVID, so our children don't have higher rates of infection and literally be 3 times more likely to die if they were Black versus if they were white. It's just inequities that literally overlap.
Well, and it goes deeper. We've talked mainly about healthcare, of course, Ebony, but our democracy is on the brink. Voter suppression, the recent Lancet report on the racial injustice that is with the arrests and imprisonment. So one of the things I wanted to get to you about was, I mentioned at the outset about Charlottesville, 2017. I don't know if you had already joined the faculty at UVA.
I literally moved here on the 1-year anniversary, and I did not even realize it was the 1-year anniversary day until the chairman wrote me and said, hey, don't go downtown. And I was like, why? It's like, just don't go downtown. I was like, oh, okay, yeah.
Can you have any reflections, even though you weren't there? Obviously, it became a focal point of this country. And it bespeaks the depth of the lesion, the disease, if you will. And Charlottesville will go down in history for that. What are your thoughts?
Yeah, and it's not just Charlottesville, unfortunately. I moved here from Charleston, South Carolina, of which we had Dylan Roof shoot up a church and unfortunately killed 9 people as they were praying for him. We had Walter Scott a few years, in between those. So it's one of those things of how do you, what is that chronic stress of living in a society of where you're constantly told you're devalued? What does that do to the activation of your HPA axis, your hypothalamus, to your pituitary gland, to your adrenal gland? If not, increase your cortisol, increase your glucagon, increase and lead to insulin resistance. All the things that we talk about as far as being chronic conditions. But one thing I can say about the city of Charlottesville is there's a lot of intentional work to talk about it. And I was really shocked, actually, at just the amount of ongoing conversation. And you can't drive down the street without seeing some sign that says, love lives here, or Black Lives Matter. I was the only Black person in my neighborhood, and literally there's like 3 signs that says Black Lives Matter in other people's windows. And you look at it, you're like, oh, okay. But it forces this conversation. But I think it has to go a step past conversation and more towards action. And again, and accountability. And like I said, with the CDC, when I tweet you, and I've been tweeting you about your initial vaccine rollout, when you come down to the booster, and I see that it's the same thing, that is still tied to age, that is still tied to employment, right? And you specifically list out that the independent risk factors for this are race, age. Then how is it that you choose one and neglect the other? So, and if you're willing to, and I'm gonna have this conversation until I don't have to have it again, look me in the eye and tell me then that Black lives don't matter, because that's what your actions are saying. And then in the words of James Baldwin, I can't believe what you say because I see what you do. He also said, I'm just a huge fan of his work, but he said, I love America more than any other country in this world. And exactly for that reason, I insist on the right to criticize her perpetually, because this is my country. And I do know how great we actually can be, but we will never be as great as our potential until we take care of the least of those. And right now we're not doing that.
Well, Ebony, this has been a memorable conversation. I mean, you're extraordinary, and we're going to be seeing a lot of you in the years ahead. Your career is the early stages. You can just imagine where you're headed. We hope that you'll inspire others to become activists like you are and help change medicine, help change our country to be a better place where it isn't now, but it can be, as you've emphasized. So we really appreciate you taking the time to visit with us and have this conversation, and all that you do each day, because this is hard work. It's not like you take a day off. And we're just so thrilled to have the chance to have the beginning of what you're going to do. The impact we know is going to be profound in the decades ahead. Thank you. This podcast is intended for U.S. healthcare professionals.